You can pull it around there. I'm sorry. Cleaning crew. You can be seated. Ladies and gentlemen of the jury, I hope you had a great weekend. We're going to continue on with the testimony. Ms. Sawyer, call your next witness.
Thank you, Your Honor. State call Dr. Wes Ely to the stand.
Doc, I need you to raise your right hand. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay, go ahead and make yourself comfortable. You've got an aerial mic there in front of you. Okay, I need you to state your name and spell it for my court reporter so she can get used to your diction.
Sure. My name is Dr. Wes Ely, W-E-S-E-L-Y.
Can you hear that, Sam? Okay.
And Your Honor, if we can have the screen down, we're going to need that with them at some point.
Okay. I would have normally put it down earlier, but
I know. Thank you, Your Honor.
what are you going to run it off of? The projector?
Overhead, I'll be running it off of. Thank you. Dr. Ely, where are you employed?
Vanderbilt University and the Veterans Affairs Administration Hospital, which are both in Nashville, Tennessee.
And what is your position with them?
I'm a professor of medicine at Vanderbilt University, and I direct a research center there called the Critical Illness, Brain Dysfunction, and Survivorship Center, CIBS, SIBS Center. And I, at those two hospitals, teach medical residents, interns, and students, and take care of patients in the medical and surgical intensive care units.
And are you a licensed physician in Tennessee?
Yes, I've been licensed to practice in Tennessee since 1998.
And what education do you have to be licensed as a physician in Tennessee?
I went to medical school at Tulane University in New Orleans, and after that trained in internal medicine at Wake Forest University in North Carolina, and then did a pulmonary medicine fellowship and then a critical care medicine fellowship. And then I trained in lung transplantation at Barnes-Jewish. The fellowships were also North Carolina. And then after training in lung transplantation, I became the medical director of lung transplant at Vanderbilt University, and then continued on in intensive care for the past 25 years there at Vanderbilt University.
And I'm sorry, sir, did you indicate when you received your licensure as a physician?
Yes, I became board certified in internal medicine in 1993 or 4, and then in pulmonary and critical care medicine in 1996 and 97. And I've kept my, I'm continue to be board certified in critical care medicine. After doing transplant for many years, I just decided I wanted to stay in critical care, so I only maintained the critical care certification at this point. So all I do is ICU medicine, so I just maintained the board certification in critical care, and I'm current in that at this time.
And that licensure and certification has remained consistent since you obtained them?
That's right.
Now, you indicated you're a teacher. Do you specialize in any areas as far as teaching at Vanderbilt University Medical Center?
I mainly teach about how you take care of the most vulnerable people in medicine, the world's sickest patients, those people who are on life support, on mechanical ventilation, on dialysis, people who have a low likelihood of surviving without critical care. And the specific areas that I research the most and care for the most are people who have, well, for example, now in COVID, I'm in the COVID ICU, been in there for a couple of years now. day in and day out with the COVID patients on life support, but also people with severe sepsis, all forms of malignancy, all forms of intracerebral bleeding, all kinds of large vessel bleeding, heart attacks, strokes. And I'm considered, I guess my area, I was trained by one of the fathers of geriatrics. So he always taught me, Wes, how do we take care of the people who are the most vulnerable, that is the elderly, and help them have a dignified dying process. So I really, in the past 15 years, have realized that my job in the ICU is not just providing procedures to help people live, but a third of my patients die by the time they leave the hospital. So I really focus on a good quality dying process, something that allows them to be shown dignity and love during their dying process, and allows them to make as much of a connection with the people that are most important in their life as possible. So, for example, during the COVID pandemic, I was one of the main people who argued with the hospital to reopen the hospital for visitation. And my patients were the first ones that got their family back to the bedside.
Now, you indicated that's been a large focus of your research over the last 15 years, is dying with dignity and helping them. Have you published papers regarding that issue?
Yes, and I never intended to make this an area of my field. I was really just kind of interested in how do we get people off of life support faster to help them survive. But what I realized was that I was carrying around a lot of shame because I wasn't focusing enough on
I believe it's non-responsive. The question was, have you ever published any article?
Yes, and I'm going to tell you how I got to that publication.
Okay, hold on. I get to make the call.
Sorry, you're right.
Okay? I'll give him a little leeway, overruled.
Okay. So you indicated yes. What got you to that point, Dr. Ely?
So I decided I needed to start publishing papers on what is the appropriate way within the bounds of our legal system to provide good end-of-life care so that people could die with dignity. And what that led me to were papers on the discrepancy between euthanasia and a good, comfortable dying process. And specifically with regard to the doctrine of double effect, for example, and publishing pro-con debates on what is allowable in medicine at the time of death versus not. And so those publications have been a big part of my career over the past few years, as the culture and society has tried to argue one way or the other for legalizing euthanasia.
Now, have some of those research and writing included evidence-based practices that are recommended throughout the nation?
Yes. In 2013, there had not been a redo of the clinical practice guidelines for the safe use of sedation and analgesia pain medications in 10 years. So I was one of the main authors on the clinical practice guidelines for the Society of Critical Care Medicine, which is to say that the society that determines the appropriate use of drugs like fentanyl and morphine published their guidelines, which were then adopted throughout the world as the authoritative guidelines on the use of these medications. And I was one of the leaders of the committee to generate those guidelines.
Now, as part of the research in regards to those areas, did it also include research and writing regarding the withdrawal of mechanical ventilators or extubation?
Yes, actually, that's how I got my entire academic career started. The idea of how to safely withdraw a mechanical ventilator has been one that's been debated for many years. And in 1996, I published a paper in the New England Journal of Medicine, which helped to outline the modern-day protocols for how to withdraw life support. And so I've been on basically most of the committees, guideline committees, and panels of experts to help teach doctors all over the world how is it that we could most safely remove these machines, both to increase survival and also, if someone isn't going to survive, how do we do it in a way that provides a comfortable dying process?
Now, the end of life, obviously, does it touch upon palliative care and hospice care?
Yes, palliative care is an area of my expertise as well. I'm currently mentoring some palliative care physicians, and we're doing NIH, that's National Institute of Health, funded research in the area of palliative care. We are determining the appropriate ways to increase the use of palliative care. I think it's an incredibly important area in medicine that we provide good, safe, and appropriate palliative care to all of our patients who are dying. And this is an area that I'm actively researching, teaching, and publishing in.
In addition to, I think I counted over 300 articles and letters, chapters and books that you've done, including chapters and textbooks, have you taught nationally and worldwide?
Yeah, actually, I have over 500 peer-reviewed publications. And I teach internationally on all continents and travel extensively throughout Asia, Africa, Latin America, the North American region. I'll be going to Brussels in a couple of weeks. And I'm on these, I do that, I don't like being away from family, but I do that because it's important for us to communicate medical advances. And there's really no way to do that without going to the places that are doing the work on the ground and helping one another learn how to do better for other people.
Now, among the topics that you teach on when you travel, does that include the best practices in ventilation withdrawal extubation?
Yes, I'm usually asked to teach on mechanical ventilation itself, withdrawal of mechanical ventilation, palliative use of drugs to keep people comfortable during that process, and to help establish the protocols by which people can approach this safely for people while staying within the bounds of law, but also using science to generate the best foot forward. We can't just wing this. We have to use the evidence. And so I always take an evidence-based approach when I'm asked to give these lectures internationally.
Now, Dr. Ely, in addition to teaching, you indicated you are actually a practicing ICU physician.
Yes, I'm very busy in the ICU. Next week, I'll be back in the ICU at the bedside with my patients, kneeling down, holding their hands, and taking care of them.
Tell us a little bit about your practice in the ICU at Vanderbilt.
Vanderbilt's a very busy intensive care unit. During the COVID pandemic, there were months where it was all COVID patients, but now we've mixed it up. And so next week when I'm in there, I will have probably 20, 25 patients at a time. I'll have medical students, residents, and interns with me, pharmacists, social workers. I make a point to make sure we have the hospital chaplains with us. And so it's a team usually of around 15 people that are going around from bed to bed. And we go in with each patient and their family and round with them for a better part of half a day, and then spend the rest of that day going back to see them again, having family conferences, being with them, and doing procedures. But really, it's more about communication and talking than it is procedures for me these days, because I just find that is the most critical part that's missed at the bedside. So many people get a bad example of communication, and then we start missing one another. So that's what happens. It's kind of a very busy 1 to 2 week block, depending on if I'm on 1 week or 2 weeks at a time.
Now, when in the ICU, are there certain tools that are used to determine the pain a ventilated patient might be suffering?
Yes, generally, and those guidelines I was talking about earlier are called the PAD guidelines, which stands for pain, analgesia, and pain anxiety, and delirium. And we have tools that are validated for use for pain monitoring, and also for anxiety monitoring, and also for delirium monitoring. And that's been a big part of my career, is developing and validating the tools. When I started this in 1998, we didn't have the tools. But now, for example, the main tool used all around the world for delirium to see if somebody's awake and alert is one that I developed called the CAM-ICU, C-A-M-ICU, and it stands for Confusion Assessment Method. for the intensive care unit. And that's a tool, all these tools that I'd helped develop are translated into over 40 languages and used on all continents to care for patients around the world to keep them safe.
And Dr. Ely, are you also familiar with the Glasgow Coma score?
Yes.
What is that exactly? I'm sorry, Coma.
The Glasgow Coma score, or the GCS, is a tool that was developed for people with brain injury, like a stroke or a bleed in their head or head trauma. It's not a good tool to be used outside of those areas. So, for example, in a COVID patient, we wouldn't even check the Glasgow Coma Scale. We would check instead the tools that I helped to validate, one of which is called the RASS, Richmond Agitation Sedation Scale, RASS. The RASS and the CAM, which I mentioned a moment ago, are the sister instruments by which we measure if somebody is awake, alert, and thoughtful, and uncomfortable. So what we do in the ICU is we couple a pain tool with an anxiety and a delirium tool, and that is our language. And we try to describe to one another how somebody is doing, and if they are suffering, we can use these valid tools to try and help understand if they indeed are suffering or if they are not suffering.
Now, you indicated you helped develop the RAS. Can you tell us a little bit about that?
Yeah, I was, at the time in 1998, everybody was using the GCS. And it didn't make any sense to me because the GCS has never been validated outside of a neuro ICU. And the majority of ICU patients aren't neuro ICU. They're pneumonia patients or heart attack patients. So a friend of mine named Kurt Sessler in Richmond had developed this tool, and I called him, and we developed it and published it in the Journal of the American Medical Association, or JAMA. JAMA is one of the top 3-tier journals in the world. Those top 3-tier journals are JAMA, Lancet, and New England Journal. And when we published this RAS tool in JAMA, it quickly became the #1 way to tell if somebody is comfortable and or sedated enough all over the world. And so the basic schema is this.
Your Honor, I think at this point we're unresponsive to the question. I'm going to have to object.
Well, I disagree. I'll overrule.
Okay. Continue,
I'll keep
Dr.
it short. This is relevant, in my opinion, because what we want to do is ask ourselves, is somebody suffering, and do I need to give more medication to cover their suffering? This is the way I practice medicine every day. And the RAS helps you understand that with the CAM and the pain tool, because otherwise I'm guessing. If the person can't communicate to me, I have to have some objective way to measure whether or not I need to give more medication. And the RAS and the CAM allow me to do that along with the pain tool.
All right.
Bottom line, I can work with my nurse.
Okay, hold on.
Okay.
That's a, bottom line is what, Dr. Ely?
Bottom line.
You ask a new question.
Okay. How is it that you and your ICU utilize that tool?
Yes. Bottom line is that I and the nurse at the bedside assess the patient objectively to see if they are still suffering. You might use my arm as an example. My wrist here is untreated suffering. And I use this example a lot with medical students. If I can see my wrist, then there is still a need for more medication. Okay? If I was able to cover my whole wrist, now, and I'm assessing with the RAS and the CAM, these tools, the tool tells me I'm good. This person is now comfortable. They do not need more medication because more would pose a risk for damage to them. It would make them stop breathing. It might make them die. So if I'm untreated suffering, I'm going to increase my morphine or my fentanyl to try and cover their suffering. But if the suffering is all taken care of, sorry for my weird way of showing you, but if the suffering is covered and we judge by these tools, by the RAS, the CAM, and the pain tool, that this patient is not currently suffering, then there is absolutely no reason to give them a higher dose of a medicine and then only cause harm. Because I want to uphold my duty of first do no harm.
Diane, it's okay if I publish first and just put it up there. Okay. Your Honor, if I may publish for the
Trying to
jury?
get it up.
All right.
It's showing on the screen here, but it's not going to the big screen. There we
There we go.
are.
All right, Dr. Ely, I'm showing you what's been marked for identification first as State's Exhibit 21, and then I'll move it down so you can actually see what it is. Can you identify this for us?
Yeah, that's the GCS.
And explain how this works based upon what we have here.
So the GCS looks at whether or not somebody's eyes are able to open when I tell them to open them, whether or not they have a verbal response if I say something to them without touching them, and if they have a motor response. And again, this tool for you, if I was to measure your GCS right now, if I don't talk too much and put you to sleep, it would you'd have a 15. So the highest is a 15. The lowest is a 3. The lowest you can get is 1 for each. But that tool was not validated for use in patients outside the neuro ICU.
Okay. And then I'm going to go to page 3 of that document, Diane. Can you tell us what this is again, State's Exhibit 21? Can you tell us what this is?
Yeah, this is important because this is what the world uses now. The world uses the RAS. And if you look at the positive numbers on the top, this is the tool that I validated and published in the Journal of the American Medical Association. So basically, we look at somebody and we say, are they restless or more combative? Which, if somebody was really uncomfortable and in need of more pain medicine or anxiety medicine, they would have positive numbers there. You see them combative, agitated, restless. You right now are a RAS 0. You're awake and alert, and you're calm. That's a RAS 0. And then we have 5 negatives, -1 through 5. Now look on the far right where it says verbal stimulation and physical stimulation. This is really, I hope will be intuitive to you, but if I talk to you and ask you to look at me, I'm not touching you, I'm only giving you a verbal stimulus, and I can tell that you do look at me and make eye contact, then I can rate you as either -1, 2, or 3. If when I ask you to look at me and respond, you do not respond at all, then I know that you're at least -4 or -5 at the very bottom there. Physical stimulation required, and you're either deeply sedated or unarousable. Okay? Now, if you are deeply sedated or unarousable, then there's very little likelihood that you need more medicine because you're already deeply sedated and unarousable. You're not responding to verbal stimulation. You can't look at me when I ask. And if I even give you a sternal rub or grab your fingernail and punch down as hard as I can, which is very painful, and you have no response, then that's how deep you are in your sedation, illness, whatever. You're basically, we call that a coma. So -4 and -5 is essentially coma. And then -1, 2, 3 is various stages of deep sedation. It would be really rare, almost unheard of for me, to give higher doses of medications when somebody is already in a coma.
All right, Dr. Ely, what type of medications are you talking about there?
Generally, I'm talking about drugs like narcotics or sedatives like benzodiazepines, Valium, midazolam, lorazepam. These are benzos, or you might know them as sleeping drugs, like Valium, like an anxiety drug. But there are other types of benzos that are more strong than that we use through a vein, and one of them is called midazolam. But the narcotics we generally give in the ICU are either morphine or fentanyl. And we would give morphine or fentanyl through the vein if their RASs were in the positive range or if they were 0 or -1 or something. We would not want to increase the dose of those drugs if somebody was -4 or -5 because, A, their pain is already covered. They don't have untreated pain and suffering. And we don't want to get the negative, the bad effect of the drug, of those drugs, fentanyl and morphine, which is to stop you from breathing.
Dr. Ely, there's another document we've heard reference to called the CPOT. Are you familiar with that?
Yes. Remember I was saying earlier that the guidelines were called the PAD guidelines, which stands for pain, anxiety, and delirium. So I've covered for you the anxiety and the delirium portion with the RAS and the CAM. We didn't cover the CAM yet, but that's a way to tell if your thinking is clear or not. But the P part, I haven't covered that yet. So the P part is, are you in pain? Now, the RAS kind of does get at it a little bit, because if you're in pain, you're probably going to be up there in the pluses. But it's possible to experience pain and not be in the pluses. So therefore, we have a CPOT, which stands for Clinical Pain Observation Tool.
And how is that used, sir?
The CPOT is a 0 to 8 tool, and when people have CPOTs in the 4, 5, 6, 7, 8 range, we judge that they are in pain. And so if somebody had a CPOT in those high ranges, we would want to give more pain medicine. But if they were down in the 0, 1, 2, or 3 range, we would judge that they didn't need more pain medication. So for example, if a nurse told me Mrs. Smith's CPOT is 3 and her RAS is -1, I would think she's not in pain and she's lightly sedated, a little drowsy. So she says those numbers, I can hear it as, how is my patient doing?
All right, I want to direct your attention up here. This is the back part of State's Exhibit 21. Can you identify this for us?
Yes, these are the ways that we measure the CPOT. So what we're doing is we're looking at the human being, because the whole idea is I'm there to serve them. So I want to know, am I serving you well enough? Are you tense? Are you grimacing? Are you protecting yourself? Are you restless and agitated? And if you're on a ventilator, one big sign of pain and discomfort on a ventilator is when you're, what it says at the bottom down there, where is it? Yeah, ventilator tolerance. Are you coughing? Are you fighting the ventilator? And we can tell if somebody's fighting a ventilator, because if I give you 10 breaths and you just take the breath, inhale, exhale, inhale, exhale, inhale, exhale. If you flow along with the ventilator the way that I told the machine to breathe for you, then you're not fighting the ventilator. But if every time I tell the ventilator to give you the breath, you exhale and fight and jump around, then I can tell, well, something's not right with Miss Smith. She's very uncomfortable. Maybe she's in pain. And that's part of the CPOT.
And this goes up to a score of 8, you indicated.
That's right.
And it's structured according to how this is laid out?
Exactly. And what we do on rounds is that the nurse assesses each patient.
Your Honor, the question was, and this is structured as this. Just responsive, please.
Okay, sustain, let's start with another question.
How would this be used in your ICU?
So what we would do on rounds is that I came up to the patient's bedside, and the nurses will usually have assessed the patient already, and they'll say, Dr. Ely or Dr. Wes, the CPOT today is a 2, the RAS is a -1 or 0, and the CAM is positive. And that gives me those 3 pieces of information. Are they in pain? Are they anxious? Where are their levels of sedation? And are they delirious? And with that, I can get a clinical picture of what's the degree of suffering that this person's enduring right now. And then we as a team will change our medication plan to try and meet their needs.
Now, just something that you just said, are these tools used alone, or are they used in cohesion with each other?
They have to be used together. They're siblings. I'm not going to take care of your pain and not pay attention to your anxiety or delirium. I'm not going to take care of your delirium and ignore the pain. So I'm trying to get a whole picture of, is my patient suffering? And if they are, I'm going to increase this medicine, because I first and foremost want to make sure somebody's not suffering. And if they aren't suffering by these valid tools, which we've studied in thousands of patients, then I'm going to make sure that we maintain that and reassess them every 4 hours. And time is on our side, because I can always go back and reassess them again and get more information from the nurses.
And Dr. Ely, these 3 tools that I showed you, the Glasgow Coma score, the RAS, and the CPOT, those are commonly used tools within your business.
Yes.
And what I just showed you are true and accurate copies of those tools?
Yes, they are.
Dr. Ely, you mentioned that typical drugs that you would use in the course of the ICU are morphine and fentanyl. Tell me a little bit about that use.
Yeah, these are really, thank goodness we have these drugs, because they allow us to alleviate the pain that somebody's having, and they allow us to do it safely if we use the right amount. The important thing about that is that each individual person has to be cared for under their own circumstances, and the downside of the medicines is such that I want to make sure that I do good and not harm. The downsides would be, minor things like constipation, but major things like stopping you from breathing and causing you to go into shock and stopping your heart. And we know that narcotics, when given in too high doses, can cause cardiovascular collapse or a drop in your blood pressure and shock, but and very, very predictably can stop you from breathing. So if somebody's not on a ventilator, for example, I need to make sure that I start low and then work my way up.
Why is that important, sir?
Well, it's important because my oath is first do no harm. And if I want to do good for somebody, but I know that a medicine can also do bad, then I'm going to err on the good side and then work my way up so that I'm going good, good, good. If bad's up here, I don't want to start up here with bad, because my goal is to help somebody and never to hurt them. And so I can start low and go high. And what we do in the ICU is I'm up there all day. So we give a medicine at 9 o'clock, a little bit. And we come back at 10 o'clock and give some more. So we commonly give them medicines each hour.
There's no objection.
Same thing as to responsiveness. The question some time ago was explain how morphine and fentanyl use.
Let me take a spin here. Doctor, I know you've got a lot to tell us, but we do it by question and answer.
Okay.
Like your procedures in the hospital, these are ours. So let's let her ask you some questions and we'll work it that way. Fair enough?
Thank you, Judge.
And you just said something about that. Now, we've heard on fentanyl several times, there's no maximum dose medically. What are your opinion on that?
There is a maximum dose of fentanyl.
Your Honor, I was just, sorry to interrupt, but I'm not sure the expert has ever been officially tendered.
Okay, well, you better go sidebar before you go there. Ladies and gentlemen, let's make yourselves busy for a second. We'll be right back with you.
Not great. Well, they're saying it's not great.
You're already in CDC guidelines.
Yeah, they just came out.
That you can have later for, a later snack.
Exactly.
Oh, yeah. Oh, they must get really dirty.
We're waiting on her, guys. We'll worry about that. It's okay. No pressure, Sam. You're fantastic. You're wonderful. and you're bound up there.
Make sure I write that part down.
No. Unless you want to, I don't care. You ready?
Yes.
Do you want to give the
Repeat the
question again?
Certainly, Your Honor. Dr. Ely, we've heard from other individuals that there is no maximum dose of fentanyl. Can you give us your opinion on that?
Yes, the maximum dose of fentanyl, or the maximum dose of fentanyl, is when the harm outweighs the good. And that gets back to the notion that there is a way that I can hurt you with any medication. And since I don't know your individual maximum, and because the maximum is so dangerous, i.e. that it would stop you from breathing, I have to stay way away from that ceiling, which is why we start lower and work our way up, rather than risking hitting or exceeding that ceiling. That's how we do the maximum dose.
Now, you indicated that the ceiling could cause you to stop breathing. Are there common side effects that could be suffered from a larger dose of fentanyl?
Yes, the common side effects would be a drop in your respiratory rate or the size of your breathing, or completely stopping breathing at all, meaning no matter what, your brain is going to not tell your body to breathe. Because the medication impairs the respiratory center in your brain, the most basic part of the brain which tells you to breathe. So if that medicine hits that respiratory center and tells you to stop breathing, then the way that it will stop you from experiencing pain is through dying and no breathing. And that is the circumstance where we say that the bad outweighed the good.
Do you have an opinion as to whether or not fentanyl used with elderly patients is good or bad?
Fentanyl can be safely used with elderly patients, and I do it. I do it making sure that I stay way away from that ceiling. Usually, for example, I would give doses of 12.5 micrograms, 25 micrograms, maybe 50 micrograms of fentanyl in a single dose, and then repeat that dose if the tools that I have tell me that there's still ongoing pain and suffering. So I would go 50, maybe if I was at 50, then maybe an hour later give another 50. And over a period of a day, I might give 24 doses, all one at a time, making sure that I stay down here in the area of good and never cross that bright line of I'm causing harm now. And that way I can give the medicine safely, keep the person comfortable, cover their pain, and make sure that I never cross over the line of causing them to stop breathing and endanger the natural life that they have been given.
All right, so you just said you might in a 24-hour time period give up to 1,200 micrograms of fentanyl. Would you ever give that all at once?
I would never give that all at once.
Why not?
Well, it's a breach of standard of care, for one thing. The medical literature is very clear on the types of doses that we give for patients who are underneath the care of palliative care. I am, by the way, a primary palliative care doctor. I can also get people who are secondary specialists in palliative care, and the literature shows us that the amount of medicines that people at the end of life get is on the order in 24 hours. And these are the types of patients that I treat with severe sepsis, COVID, cancers, whatever, on the order of around 25 milligrams of on the order within 24 hours of 200 milligrams of morphine over a 24-hour period, which would be in the neighborhood of maybe 1,000 to 2,000 micrograms of fentanyl in a 24-hour period. Divide that up by 24, and you're talking 2,000 divided by 24, you're less than 100 micrograms an hour. So that's why I was saying before that we might give 50 to 75 micrograms of fentanyl an hour on average for dying patients. I have given max ever over that, 100, 150 micrograms of fentanyl in a single dose. The highest dose of fentanyl I ever gave in a single dose was 200. And it was to a person who had been receiving fentanyl for 10 days hourly. So, and they had evidence of ongoing pain and suffering from cancer in their bones, broken bones. But I would never give over even 300 micrograms in a single dose for fear of killing them.
All right, now you just indicated the largest dose you gave was because that patient had been on fentanyl for several times. Is that what we call opioid tolerance?
Yes, when someone is given opiates over a period of days, their body builds up a tolerance to the medication, which then allows them to receive a higher dose without stopping breathing. And that does not accrue, that tolerance does not accrue in hours, it accrues in days. So I don't escalate the dose largely in a matter of hours. I always go very slowly increasing. For example, I might go 2 milligrams of morphine, 4 milligrams of morphine, 6 milligrams of morphine, but I'd always give 2, 2, 2, 4, 4, 4, 6, 6, 6, and spread this out over a period of days before I would ever get up to 20 milligrams of morphine. And the way that morphine and fentanyl are converted is by a factor of 10. So 10 of morphine is 100 micrograms of fentanyl. It's different units. 10 milligrams of morphine is 100 micrograms of fentanyl.
And so I'm going to direct your attention to the screen. And I'm showing what's been marked for identification as State's Exhibit 19. Is that essentially what you just said?
Yes, look at the second row, which says fentanyl 10 micrograms is 0.1 of morphine. I think it's easier just to think of it as 110.
Okay, hold on. Can you guys see that?
Conversion factor.
Or do you want
A little bit,
Enlarge
zoom
it.
in.
Max and 1.
to zoom it in?
I'm working on it. How's that?
That actually, is that morphine equivalence? Let me see.
Hold on. Can you guys see that better, or do you need it bigger?
So State's Exhibit 19, this would be a conversion chart, and is that to a reasonable degree of your medical certainty?
I'm looking for the morphine.
I believe it's under hydromorphone is what they're talking about, and
Oh,
then,
equivalence of morphine. I see. Yeah. Oh, I see. Okay, yeah. That's right. Yeah, so that factors what I just said. Yeah, 10 and 100. Yeah,
okay. And that's to a reasonable degree of medical certainty?
it is.
When we're talking about opioid tolerance, how does a drug addiction, street drug addiction, factor into that in your practice?
Well, if somebody was a chronic, if somebody suffered from addiction, then they would accrue tolerance over time. Unfortunately, I don't know if I'm allowed to keep going with that, but street drug people who are suffering from addiction still die readily when they overdose on a given medication. And right now in our country, fentanyl is the main thing causing most of the deaths that I care for in the ICU. When patients come in overdosed and have had a stroke or brain dead, it's usually now because of fentanyl.
So how would that affect the ability to administer medical fentanyl to a drug overdose who overdosed from fentanyl?
Would you mind rewording that?
Sure. How would that affect your practice if they're on a ventilator, they're in your ICU, you know that they've overdosed on fentanyl? How would that affect what you give them as far as medication while they're on the ventilator?
Well, I wouldn't, if they had overdosed on fentanyl, I wouldn't give them more fentanyl right then, obviously. I would try and achieve my, achieve the covering of their suffering by some other medicine, because I don't want to continue to pile on to the problem they already have. Is that an adequate answer for you?
Sure. What if they've overdosed on other drugs, like cocaine?
Yeah,
How would that
anytime
affect?
somebody has overdosed on a drug, I try and avoid that same class of drugs as I'm caring for them until I know that that drug is cleared out of their body.
And how would it get cleared out of their body, sir?
The kidneys and the liver generally clear the drugs. Fentanyl has a half-life of a couple of hours, so when I give it, it's going to last not for days, but it's going to last for a couple of hours, and that's why we dose it hourly or every 2 hourly.
All right, now you just indicated it is assimilated through the kidney and the liver. What if there's damage to those organs?
If there's damage to the organs, depending on the drug, because some drugs are more kidney cleared and some drugs are more liver cleared, but we try and pay attention to whether or not somebody has those organs damaged, and we would have to use much lower doses. If they had like kidney damage, we'd have to use much lower doses.
Why is that, sir?
Because the drug will build up much faster and the toxic effect of the medication would be more profound if we don't factor that in, because they have no way of clearing the drug.
Now, Dr. Ely, we've also heard the term chest rigidity used with fentanyl. Are you familiar with that?
Yes, if we give a high dose of fentanyl, think 500 micrograms or more, then the person can get chest rigidity, meaning that they can't breathe. So now you have a second cause of suffocation, is that one is the brain is not telling them to breathe, but the other one is that physically there is this extreme chest rigidity, and so that's another reason why I don't want to get anywhere near those sorts of doses.
What about the use of fentanyl in the extubation, palliative extubation? Have you ever done that?
Yes, I have. When I am extubating patients and have made an agreement with the families on the patient's behalf to keep them comfortable, I want to make sure that I give them drugs that will make sure they're not short of breath. So narcotics have a beauty about them in that they relieve us from feeling short of breath if used in low doses. And when somebody is taken off of a ventilator, I will commonly give them a narcotic so that they don't experience suffocation as they're dying. And the doses that I would give that in would be something like 50 micrograms of fentanyl, maybe 100 micrograms of fentanyl. And that way, I'm only treating the suffering of the suffocation, but not crossing over into the badness of stopping them from breathing. So it's that tightrope, that delicate balance that I want to walk with them to do them good and never to harm them.
Now, doctor, obviously you've done palliative withdrawals, extubations in your practice,
Thousands of times.
and you've actually developed evidence-based protocols for such.
Yes, we have a very standard way of withdrawing the life support. We never say withdraw care, because we're never going to stop caring for this loved one, but we do withdraw support. And we withdraw support by pulling the tube out and providing them, assessing them objectively with the RAS and the CPOT and the CAM if they're suffering or not. And as we're pulling the tube out and we watch them carefully, we see, are they suffering? And usually over the ensuing 12, 24 hours, we will give them multiple doses of medications if we see any suffering. If we don't see suffering, then we don't give them those medications, because if there's no suffering, the medicine can only harm them. Another way of saying that is, if the medicine can't help them, it's only going to hurt them.
So can you give us an example of how you would do a palliative extubation, as far as what medication you would use, how you would approach it, that type of information?
Sure. I would work with the nurse and the team, these many people I've got, and we would address a human being as mind, body, and spirit. So we would address their cognitive issues and suffering, their body and their spirit. So we would make sure that the body and mind were addressed with morphine and fentanyl, morphine and maybe a small dose of a benzodiazepine. And so I would say to the nurse, let's give them 2 milligrams of morphine and 25 or 50, and maybe 2 milligrams of a benzodiazepine, Valium or midazolam. If they were on fentanyl, I might say, let's give them a dose of 50 micrograms of fentanyl and 2 milligrams of a benzodiazepine. And we can repeat that dose every hour as you're watching them very carefully, depending on if they are exhibiting a rise in their CPOT. Their CPOT goes from 2 to 7. Oh my goodness, no, they're in pain. Let's increase that fentanyl. Let's go to 100 now. At 9 o'clock, we gave them 50. The CPOT now has gone up to 7. We need to go up to 100 of fentanyl now. So let's double that dose. And it's all through the medical literature shown that the way that we do that commonly in the last 24 hours is we will often double and sometimes even triple the dose. So I might go from 50 of fentanyl to 150 of fentanyl. And that's well established as the right way to do palliative care.
Does it make a difference if that patient is conscious or not as you withdraw them from the vent?
Either way, I would take the same approach, but usually it's just that the conscious person will be more likely to be able to express to me or show to me that they were suffering. The unconscious person, since they can't, that's why we want to use the tools. So when the unconscious person, super important then to use the CPOT and the RAS, because they can't tell me, but I can watch their respiratory rate. I can see if they respond to verbal or if they're grimacing and such.
Do you give pain medication in anticipation of pain that's going to occur with extubation?
Well, we do try and stay ahead of this. So we don't wait until they show pain, but we don't try and jump too far ahead either. So there's this balance. It's all about judicious use of the medicines. And what we talk about, what I teach the medical students is, don't let someone develop a huge amount of suffering, but the easiest way is to give little bits to stay ahead. If this is suffering and this is the medicine and their suffering is increasing, I'm going to stay just slightly ahead, but I'm not going to do this. Here's suffering, here's the medicine. I'm going to stay right ahead of it. And I can do that. We do that every day by just watching the person very carefully.
Why don't you jump ahead to the high dose?
Because I'm trying to do them good. So here's their suffering, and here's the medicine coverage of the suffering. If I stay like this and dose them every hour, then I never jump up here, which causes them to stop breathing and ends their life. It's the difference between, what I'm trying to do is allow the person to die of their natural disease process. Because I am never there to deliberately shorten their life. I don't want to make a somebody into a nobody, okay? I want to allow their natural disease process to take its natural course, and that is like a candle burning out, okay? I'm not trying to blow the candle out. And if I jump up ahead with the medicines, now I'm blowing the candle out, and that's not my right, and it's illegal.
In your opinion, is a palliative care extubation ever an emergency?
It's never an emergency because what we're trying to do is get all of an assessment of what this human being wants, what matters to that person. So we have to be cautious and careful and talk. And they're already on life support right now. We've already got them covered with some form of medication, and we're already watching their suffering. All we're trying to do, so everything is stable, all we're trying to do is say, when is this life support now not meeting the requirements of this person's preferences? And if we think that the person would no longer want that life support, then we, in respect of their wishes, will remove that life support, but it's not an emergency. We have to make sure we get it right. And so we take our time. And we almost never do that in the middle of the night.
Why not?
Because in the middle of the night, families are suffering. The family is suffering. The family is hurting. They're scared. They are in physical and existential pain. So we want that family to be at home, resting if possible, or asleep in the bed next to their loved one. And I don't know what sort of conversation or things that family needs to say to their loved one to help them heal. So I don't want to rush that. And I don't want to do it under the cloak of darkness. I want to allow people to get their sleep. I want to allow them to have the sun up and to be present with their loved one as the dying process goes. And that if we do it at night, it makes it seem like there's some sort of urgency. And then what happens is the family doesn't feel comfortable communicating that love. I've seen relationships rebuild and reconcile even when it's only a one-way conversation. I want to allow that to take its natural course.
What if the family comes to you and say, I want to do it now, doctor, now?
If the family wants to do it right then I try and respect them, but I find out, is this in keeping with your loved one's preferences, and what changed that makes you feel like this is urgent? And so I still try and instill back into the conversation some degree of a pace.
And that's something that comes up. What is your obligation as the physician to the family when you're in the middle of a palliative extubation?
I am there to serve the patient, and in so doing, I must serve the family. So I'm of service to the family.
And when you say you're going to service the family, if it comes down to something that's best for the patients versus best for the family, what's the overriding factor that you have to look at?
What's the best interest of the patient?
And why is that, sir?
Because I am that patient's physician, and it is my duty as a healer to be present with that person to serve their needs, whether it be a comfortable dying process or a curative medication or procedure. They're my primary obligation. The reason I said earlier that I'm there to serve the family is that the patient is oftentimes not able to communicate to me, so the family is my conduit to understand how to serve the patient.
Now, the drugs you administer, what is the purpose of those in palliative extubation?
The purpose of those medications is to try and mitigate or reduce suffering, reduce human suffering.
And we've had some testimony about the synergistic effect of opiates and benzodiazepines. Can you explain that to us, please, sir?
Yes, all that means is that if I give you fentanyl, there is some degree of suppression of your brain telling you to breathe. But if I give you fentanyl and a benzo, or for example, midazolam, it's not just additive, it's exponential. The brain is now getting pummeled in two different directions by two different chemical compounds, telling the center in the midbrain to say, don't breathe anymore. Don't stop, don't send any signal to breathe. And so it's very dangerous to give both medications if we don't monitor the person carefully. Now I do it, but I do it, as I said earlier, very low doses, and I grow it over time, but I would never start high because I would think that I'm going to achieve that ceiling and cause some harm, like death.
Now, there's been also some discussion in the courtroom about opiates hastening the death of the patient in a palliative extubation. Can you talk about that?
Yeah, generally, we do not think that opiates hasten death when they are used in the right doses. If you read any article about palliative care and opiates, most of the articles are actually geared towards making me comfortable to give the opiates. And this is something very important. In the 1990s and early 2000s, there was a general fear of doctors giving opiates, and people died suffering. And that was wrong. And so lots of articles, including investigator friends of mine and ourselves, wrote papers to say, don't be afraid to give these drugs in doses of 2 milligrams, 10 milligrams of morphine, 50 milligrams of fentanyl, 100 milligrams of fentanyl. These doses help people to die comfortably. So the literature's filled with directives that say narcotics don't increase the likelihood of dying. But none of those articles are using doses of 500 micrograms of fentanyl, 1,000 micrograms of fentanyl, 1,500 micrograms of fentanyl. Those are never used in clinical practice to mine. I've never done that. In my whole 30 years of practicing medicine, I've never given a dose of this drug like that. And the reason that none of us would do that is that we know that there's no clinical benefit at that circumstance. We can achieve the goodness that we need to achieve at much, much lower doses and keep the person safe.
Now, Dr. Ely, some of the things that have been discussed that could cause pain to a patient for palliative extubation would be a high lactic acid or acidosis. Can you tell us about that?
Yeah, if you exercise and you build up lactic acid in your thighs hurt. It's what stops somebody from running faster. You know, the lactic acid builds up. And in the ICU, patients do get lactic acid. That is not, the way we measure if they're in pain from lactic acid is the CPOT and the RAS, you see. So we don't need a real-time lactic acid level to tell us if they're in pain because we have these valid tools which allow us to do it right then and there. So I would never say to the nurse, what's their lactic acid? I need to know if they're in pain. No, because I would say instead, what's their CPOT? What's their RAS? If that CPOT's rising, we need to give more pain medication.
What about if they've been administered CPR? How would that affect their pain level?
If they've had CPR, then they have what we call a nidus of pain, a source of pain, because they could have had broken ribs or something. But again, we go straight back to where's their CPOT, where's their RAS, because I don't know. So I need this objective information, and that's what we need in times of confusion is how do I get recentered to know what I'm doing? And the RAS and the CPOT are like our compass. You know, if I want to know where I'm going with this person, then I need to have my compass, and these are the clinical bedside evaluations of each patient that I care for.
And the pain medication you're giving, is it there to help treat the respiratory distress when you remove the ventilator?
If the person starts breathing really fast and appears short of breath, then I would assume that they are sensing the suffocation. And then I would respond by asking the nurse to give 50 to 100 mics of fentanyl and maybe 1 or 2 milligrams of a benzodiazepine. And that would keep them calmer and make them not aware of that suffocation. But that's a low dose that takes care of the bad and achieves me some good without causing bad.
Now, another term we have heard is agonal breathing. What is that, sir?
Yeah, agonal breathing is when, if you have a lot of fluid in your lungs or pneumonia in your lungs, and you can't take a nice deep breath, so somebody is strapping you down and you feel like you need more air, but you can't, then I put you on a ventilator. On the ventilator, you're cared for, and so you no longer are agonal. But when I take that ventilator away to allow you to die your natural dying process, when I remove that positive ventilator help, you're on your own. And so you will struggle as you breathe to some degree, maybe, and you'll show me that you're having trouble breathing. And so that's why I say to the nurse, let's give them a little morphine and or fentanyl to make sure that they can't sense that. I want to tell their brain to stop being aware of that sensation. And we do that every day. And we do it with, as I said earlier, broken record, 2 milligrams, 4 milligrams morphine. If they've been on those drugs for a week, I might be up to higher doses. It could be that I'm at 15 milligrams of morphine, 20 milligrams even sometimes, but rare. Remember, even if I'm at 20 milligrams of morphine, that's 200 of fentanyl. So you see, I'm still in the 50 to 200 range of fentanyl, even when they have tolerance.
How would you prepare the family for something like agonal breathing?
That's a really important role of mine. I need to tell them, when we remove this tube, we're doing this because you have helped me to understand that your loved one would no longer want this life support. When we remove it, though, they might look uncomfortable, and I want you to be aware that I will protect them from feeling this discomfort. And the way that I'm going to do that, and I say this out loud, the way that I'm going to do that is I'm going to give them a narcotic, which is going to tell their brain not to be aware of this sensation. So they might look like they're short of breath to you, but trust me that we are doing our best to make sure they're not aware of that. So what I want you to do instead is hold their hand, whisper to them, tell them you love them, and tell them anything you need to know. And that way it gives the family the comfort level of talking to them, even though they see something that looks uncomfortable.
Now, one of the medications that we've heard about a lot is vasopressors. What are vasopressors, Dr. Ely?
Yeah, we call them vasopressors.
Vasopressors.
And vasopressors are medications to lift your blood pressure when you're in shock. So if you're in the parking lot today and a car falls on them and you need to lift that car up, you might get a surge of adrenaline and allows you to lift that car. He's, Superman. That's a vasopressor. Your body did it. But when you're sick, your body might not be able to do that. So I could give it to you through the vein, and it just means that you're in shock. And we give these epinephrine or adrenaline drugs to get the blood pressure up.
What happens if you would remove them from the vasopressors?
If we remove them from the vasopressors, then usually, and we do this, it will make the blood pressure then plummet, and they will die of natural causes. They'll die naturally, which often means, by the way, that we don't need much in the way of morphine or fentanyl, because their dying process is going to be rapid anyway. And so I can usually give them very low, very, very low doses if they're already on vasopressors. In other words, I'll say it another way. If you are on vasopressors and I'm removing life support, it means that I very likely need to give you almost nothing in the way of fentanyl, morphine, or benzos, because you're going to die very rapidly anyway, usually. It could still be hours to days, but it might not be that long. But I don't feel the need to keep ramping up these medicines because it's going to happen by nature. So there's no reason to impart a human action to cause that dying process.
All right, and we've heard that there is two ways of dying, by your heart stopping or you stop breathing. Can you comment on that?
Yeah, medically, cardiorespiratory, so heart, lung. So when you die of either of these two organs stopping, they usually kind of occur together. It's very rarely one or the other. Because if you are stopping breathing, it stops oxygen from getting to your heart, so your heart stops too. You see? And if your heart stops, you stop pumping blood, which then makes your lungs fail as well. So these things kind of go in tandem. So I'm never at the bedside thinking that was purely lung or that was purely heart. It's usually kind of all of that happening at once. Is that what you kind of wanted to know?
Thank you. One of the first things you had mentioned when you took the stand was the doctrine of double effect. We've heard a lot about that. Can you explain it to us so us laymen understand it, sir?
Yes, okay. So the doctrine of double effect means that when I do something to try and help you, it might also harm you. And as long as I am always trying to help you, if the harm occurs, but it wasn't the intent, then it's happening as a double effect of the medication. So the medicine has essentially a capacity to do two things. I'm going to try and say this for you kind of two different ways, okay? The medicine has a capacity to help you, and it has a capacity to hurt you. The doctrine of double effect is said to be in place if I'm intending good and never harm, if the good is not achieved by the harm, and if the good outweighs the harm. I'm going to say these again. And a fourth criteria, that the good couldn't have been achieved any other way. I'll say them again. The good has to be the intent, never the bad. The good cannot be achieved by the bad. The good should outweigh the bad. And there can't be any other way to achieve the good. Now I'm going to give you an example and I'll stop talking.
Okay,
I think it's unresponsive at this point.
I can ask another next question. Can you give us an example, Dr. Ely?
Yes, here's an example. If a person is in pain or is short of breath, and I want to relieve that suffering, okay, I can give a low dose of a narcotic to tell the brain to stop, to relieve their awareness of the suffering or relieve the pain, and to try and help them. Okay. If, however, this is how the doctrine of a double effect would not be in play. This is how I would reach the doctrine of double effect. If instead of giving the low dose, I gave something that hit the ceiling, and now the way that I achieved the relief of the pain and the shortness of breath was by stopping their breathing and their dying occurred, because now the death, which is the bad, caused by my drug, has outweighed the good. The good was achieved by the bad. And I could have achieved the good by just giving a low dose. All I had to do was give 100 instead of 1,000 or 500. If I had given 100, I would have done something helpful without causing the stopping of breathing. Their dying process could take its natural course. I wouldn't have created that because of my medication. Is that helpful?
So, does the literature support what you just told us about looking at the dose?
The literature supports that it is appropriate to cautiously use these medications. And I told you earlier, an average dose, even in the last moments of death, would be, the high doses would be in the neighborhood of 200 micrograms of fentanyl, would be on the high end. And this is supported by the medical literature. And that is a way to go. There's no literature on using 500 micrograms, 1,000 micrograms, 1,500 micrograms of fentanyl. There's no literature on that at all, because nobody does that. So I couldn't find anything in the literature of routine use of those doses.
So, in your opinion, with those type of doses you're talking about, 500, 1,000, 2,000, could be purposeful to cause the death?
Objection, Your Honor.
Let's rephrase.
Okay. Those type of doses, how would you take that as to demonstrate what the intent is of the physician?
The only logical intent that I can come up with for using those doses is to stop somebody from breathing entirely.
And that would lead to death?
It would lead to death, certain death. It would be a lethal dose.
So would you agree with me at most purposeful, at the least reckless?
Objection, Your Honor.
Okay. Format of the question, sustained.
Sure. That type of dosage, would you say that that would be purposeful action?
Objection, Your Honor.
Okay, again, form of the question.
Okay. How would you define that type of dosage as far as the intent?
Objection, Your Honor, as to how does he define intent. Intent is a legal term, and I don't believe he set forth any qualifications with respect to him having a JD.
Again, form of the question.
Medically, those type of doses given to a patient in palliative extubation, what do you believe the intent of that physician would be?
Same objection.
This time overruled.
I believe the intent would be to stop breathing and hasten death, cause death.
That's to a medical standard, correct?
Yes.
Your Honor, I'm next intending to get into the actual victims in this case. I don't know if
Maybe
this
it's
would be a
time
good
for a
time to take a
break
break.
We're going to give you your early 15 minutes. Okay? Remember the admonitions.
All right.
Have a wonderful break, ladies and gentlemen. them get out of the way since you guys have to cross each other. When we discussed the construction of these courtrooms, that was one of our complaints, but unfortunately, we weren't writing the check, so we do sanitize that area.
Thank you.
So it was